Well, thank you so much for that kind welcome. I'm very happy to be here, partly because I have been hearing for several years about leadership on health equity in Louisville. So it's really exciting to be here. The one thing that I'm not so happy about is that Dr. Henry Sanchez's talk was so great. It's a really tough act to follow. But apart from that, I'm delighted to be here. So the title of my talk is The Social Determinants of Health Equity. We Know Enough to Act Now. And why did I pick this topic? In my experience, there are often efforts to increase health equity are paralyzed or undermined by someone saying, look, we don't have the science. We don't know enough now to act. We have to wait until research tells us more. And that although these sorts of pronouncements come mostly from academics, they can be very influential in policy circles because it's a very convenient excuse for politicians not to act when that is said. So I would like to address that issue. And here we go. So first, I want to cover some definitions. And you can't define health equity without defining the sister concept of health disparities. So in defining health disparities, I want you to look at this cartoon in which you see these two pretty well-fed looking gents sitting in what looks like an exclusive men's club. And one of them is saying to the other, well, the poor are getting poorer, but with the rich getting richer, it all averages out in the long run. And the point is that when we're focusing on health disparities, when we're focusing on health equity, we're not focusing on averages. So averages are really important. But that's not what we're focusing on when we're focusing on disparities in equity. We're focusing on how groups who are worse off are doing, how they are faring relative to groups who are well off. Okay. So the concepts of health disparities and health equity have at their core a notion of justice. I think they rest on concepts and principles from the fields both of ethics and of human rights, and I don't have enough time to talk about that more. But just to say in brief that health disparities are they're not any old health differences. There are many health differences, including many important health differences that aren't health disparities. That when we talk about health disparities, we're referring to a very particular subset of differences in health that are tightly linked with social advantage and social disadvantage. They are health disparities and are differences that adversely affect groups of people who are already at a disadvantage, economically and or socially. So for example, economically, socially disadvantaged groups include African Americans, Latinos, low income, disabled, LGBT, many categories of people who, because of historical discrimination or marginalization, have worse health, based on the conditions, largely based on the conditions in which they live. And so you can think of health equity in the briefest possible way or general way as referring to fairness and justice in pursuing the best possible health for all. So why do I say that? There are a couple of ways to make health disparities narrow. One is to bring up the groups that are not doing well. The other is to bring down the groups that are doing well. But that's not health equity, bringing down. We're going for an improvement for everybody, but particularly for those who have been left behind. So just one more definition, the social determinants of health. It's quite a mouthful. What I've realized is that although it's becoming more common, and it's now just you hear it outside of academia, but there's some misconceptions about what's meant by the social determinants of health. So What I'm referring to when I mention the social determinants of health, I'm talking about factors apart from medical care that have very important influences on health and that can be shaped by social policies. Examples would be childcare, education, income, housing, conditions in neighborhoods, conditions in workplaces. All of those would be social determinants of health. Health equity implies addressing the social determinants of health as well as the medical determinants of health. And why? Why is this so? Well, let's consider how important social determinants of health are. Because I think that the first thing for most people, if you say health, they think of health care. That I think is kind of, firmly embedded in our brains, almost an equation of health and health care. But just how important are the social determinants of health? And there's going to be some overlap between some of the material I'm going to be presenting to you and what Dr. Henry Sanchez did, and I hope that will be reinforcing rather than boring. So at this point, I want to pose a question, and that Dr. Henry Sanchez referred to this. How could it possibly be that in the U.S. we spend more on medical care than any other country on the face of the earth, and yet we consistently rank at or near the bottom among industrialized countries on measures of health? This just shows where we rank on life expectancy. But a recent report that came out of the National Research Council and the Institute of Medicine looked across hundreds of health indicators, including life expectancy, but many others as well, looked at all ages and found that for the vast majority of health indicators and at all ages except over 75, Americans do worse than people in other affluent countries. The comparison was with 16 other comparably affluent democracies. Okay. So how is it? What could possibly explain this? So now I'd like to show you what I hope will be some clues, the answer. Now, for those of you how many here went to public health school at some point in their? Okay. Well, then those of you who went to public health school may recognize the next few graphics that I'm going to show you. These come from work from the Scottish physician Thomas McCune. This was published in the 1970s. And he used vital statistics in England and Wales, which go all the way back to the middle of the 19th century. And at that time, since he was publishing in the early 70s, his data went through the early 60s. He traced mortality in England and Wales due to different causes. And here you see what he found for infant mortality. And you see in the last half of the 19th century, it's a kind of wavy baseline. Not much is changing. But then at around the turn of the 20th century, you start to see this sharp decline, and it's very, 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 very sharp, and that is continuing throughout the first half of the 20th century. Now, how often have you heard people say, at around 1900, people the average life expectancy was only around 42 years, and now it's around 78 years or 79 years, and you see what medical care has done for us. And I think most of us have been conditioned to believe that the great advances in longevity are largely attributable to medical care. But what McCune showed was something that challenges that. Because you see that before, we did not have the modern modalities of medical care really until the 1940s. We didn't have antibiotics before around 1939, 1940, and it wasn't really until we were into World War II that antibiotics were widely available. If we're thinking about infant mortality here, it wasn't NICUs that could explain this decline that that happened, because long before the neonatal intensive care units didn't come into being really until the 60s. And this decline, as you can see, was very, very well established before then. He looked at mortality from scarlet fever in children, also in England and Wales. And you see this precipitous decline in the last half of the 19th century, and then a kind of leveling out with gradual improvement, but on a much smaller scale into the 20th century. Well, again, the antibiotics, which would be how you would prevent mortality with due to scarlet fever, were not available until around 1940. So it wasn't medical care. And now measles mortality, again, among children. And you see this similar picture to the infant mortality one, where it's a kind of wavy baseline in the last half of the 19th century. And then there's a decline. The decline here begins a little bit later than it did for infant mortality, starting at around 1910. You see this really impressive decline in mortality from measles. So what was that due to? Well, immunization hadn't even begun, actually, before the before the curve had already reached the x-axis, so that you couldn't see it here. And then antibiotics to treat the bacterial superinfection that is the cause of mortality from measles. The antibiotics, again, weren't available until around 1940. So there's been a lot of controversy in public health about the interpretation of McCune's findings. And I think a lot of us feel that he didn't give enough credit to public health measures, but that he really did show in a very dramatic way that the major advances in longevity, in life expectancy that we have enjoyed over the last 150 years really were not due to medical care at all. And what most people believe is that they were due to advances in basic living conditions. So it was nutrition, it was sanitation, it was ventilation, working conditions, that those really were the reasons. And for those of you in infectious disease or nutrition, you also know that, when is the last time, anybody heard of a child dying of measles? It's practically unheard of in this country. The real reason that children die of measles is malnourishment. But well-nourished kids don't die of measles with or without antibiotics. So maybe some more clues. And here, what you see are data on life expectancy, separately for men and for women, men on the left, women on the right. And here, we are showing life expectancy according to income. And our measure of income here takes into account the family size. So it's basically a percentage of the federal poverty level. And I'm going to show you a series of graphs, actually, in which we'll be showing different health indicators according to income. And it will always be that the poor are on the left, and then over on the far right is the highest income group. And the highest income group for all of these analyses are people with incomes greater than or equal to 4 times the federal poverty level, 400% of the federal poverty level. Then you have the poor, that's people at or under 100% of the federal poverty level, and then the groups in between, which sometimes are a little bit different. And what you see is a 6 to 8 year difference in life expectancy. These are recent U.S. data. 6 to 8 year life expectancy difference for both men and women according to income level. I think that's pretty shocking in an industrialized country like this to see such big differences. But you may be less surprised by that, the comparison of the extremes, then you will be by looking at what's happening in the middle there. So those middle groups there, the pale blue group, the one just next to the green group, these are people with incomes from just over 200% of the federal poverty level up to just under 400% of the federal poverty level. So they're not poor, not low income. They would be classified as middle class. There's a 2-year difference in life expectancy between that group and the group with the higher income. I think this is a very important clue to keep in mind, and I'll discuss that further. This stepwise pattern that you see with health improving as income increases has been called the socioeconomic gradient in health, referring to the graded relationship. For those of you in science and the clinicians, you also might call it a dose-response relationship. Okay. This is looking at child health as reported by parents, a widely used measure of child health, and how that varies by family income. And here we could look at more income groups. So it's still the poor on the left and those with incomes 400% of the federal poverty level or higher on the far right. And then it goes up by 100% increments the federal poverty level from left to right. And you see that a child in a poor family is 7 times as likely to have fair or poor health as a child in the most affluent family. And I want to comment also that the most affluent family here, these are not wealthy people. 400% of the federal poverty level would be an income level of about $88,000 for a family of 4. So solid middle class, but not wealthy. And once again, you see a smaller difference than between the poor and the most affluent group. But when you look at the groups next to the highest income group, you see a very substantial difference. And here, that the group in the green, those people with incomes from 3 to just under 4 times the federal poverty level, so very definitely middle class. Despite that, they do worse than the people who are more affluent. Okay. And then here, looking at adults' self-reported poor or fair health, another widely used measure correlated with clinical assessments. How adults' self-reported poor or fair health varies by income, and you see a graded relationship. Since this is an adverse outcome, you see it going down. So with every step, as income gets higher, you see health improving. And I want to comment here that, of course, these associations don't prove causation. These don't prove that income caused these differences in health. But there's an enormous literature using a variety of methods to minimize the chances of bias and confounding that does tell us that income does indeed play a causal role with health. And I'll talk a little bit more about that in a minute. It's not income itself, it's what income can buy. And I also want to comment that each of these slides that I've shown you where I've commented on the pattern by income, it's a basically similar story when we looked by education. We looked at scores of different health indicators. We did this a few years ago, and what we found was that for non-Hispanic whites, non-Hispanic blacks, this stepwise gradient with health improving as income or education went up, that was the dominant pattern. For Hispanics, that wasn't as consistent. We could certainly see that pattern for Hispanics in many cases, but not half or more of the cases. Okay. So in the U.S., unfortunately, we've had this long tradition of reporting public health data by race, but not by markers of socioeconomic conditions like education or income. And I think, and I think there are many people who agree, that this has had the unfortunate consequence of reinforcing some very incorrect notions about the basis for racial and ethnic differences in health. And so when we show the data on the income gradient in health or the education gradient in health, at times the response that we've gotten, my colleagues and I have gotten, is, oh, isn't that just about race? In other words, they're saying that those differences, it's not really due to income, that it's due to race. And to answer that question, then we've done this and another analysis. This one, in which we're looking again at adults' health, adult self-reported health by income, but this time we've separated it into the three larger racial or ethnic groups. And what you can see is that graded relationship of income with health is every bit as striking within each racial and ethnic group as it is for everyone. So in other words, the take home here is that the observed income differences are not due to race at all. It's really something about income. And now here, we were able to do this with even more racial or ethnic groups because the data source that we had for this, and it was just the same picture. Here we looked by education, just to show that the graded relationship of education with multiple health measures, in this case it's adult health, that you see that within each racial or ethnic group. Okay. So I think this, if we're going to be able to answer the question, why is it that we have worse health in the US than in any other industrialized country, and yet we spend so much on medical care, I think we have to take a step back and say, well, what really does influence health? And we know that medical care influences health. When you're sick, that's what you want, is medical care. We know that age, sex, genetic makeup influence health. Dr. Henry Sanchez mentioned, though, epigenetics and how the environment can alter whether the genetic makeup gets expressed or not, and I'll come back to that. Obviously, climate could matter. If you live in the tropics, there are going to be certain health risks that aren't going to be there if you're living in a temperate zone. And in the last 4 to 5 decades, there's been an increasing awareness of the role of behaviors as influences on health. We know that nutrition is important for health. But I would like to walk you through thinking about, well, what else? And not only what else influences health, but what influences the influences? What influences who gets medical care? What influences the behaviors? What influences nutrition? And then also what we know about plausible biological mechanisms. Okay. So if you think about how income or wealth could affect health, there are some pretty obvious ways, and medical care is one of them. But also the options that you have for housing. Can you afford to buy or rent a home that is not going to expose your child to lead or to dust mites, mold, and other hazards? A healthy diet costs more than an unhealthy diet. Physical activity options, if you can afford to belong to a gym, or if you could afford to buy or rent a home in a neighborhood where it's safe and pleasant to exercise. Those are just some examples. Income largely determines your neighborhood conditions. What kind of neighborhood can you afford to buy or rent a home in? And I'll talk more about that in a minute. And then income has a huge influence on how much stress we face. And what you can think about it as is who has the resources What are the resources that different people have to cope with life's daily challenges? And I'll talk a little bit more about that. But all of this, what I've just been talking about, is how the income of an individual can influence that individual's health in their lifetime. But I think we need to think about it in a generational, intergenerational context. Because if you think about it for a second, the income of the parents actually shapes the next generation's education. How is that? Well, again, could the parents afford to buy or rent a home in a neighborhood that has good schools? Or if there weren't good schools in that neighborhood, could they afford to send the child to a private school? For most of us, education is that's the big determinant of the work that we will be able to get. And then that work is the big determinant of the income level we will have. And so that parents' income is shaping the next generation's standard of living, their living and working conditions, in very, very powerful ways that I think we sometimes don't take into consideration enough. Now, I mentioned neighborhood. One of the ways that income can influence health is through its effects on the kind of neighborhood that we can live in. So how could a neighborhood affect health? What do we know about how a neighborhood could affect health? Some of the answers to that are very obvious in terms of safe places to exercise, access to healthy food. Ads for harmful substances are clearly concentrated in poor and largely communities of color. But there are some less obvious ways, and there's a literature, I think a very credible literature, that tells us that neighborhoods can also influence health, particularly the health of children, by shaping who the peers are, what the peer pressure is, what are the norms in the community, what are the role models, and that these can shape health by shaping health behaviors, and that kids are particularly susceptible. I think that there's reason to believe that neighborhood conditions can affect stress, fear, anxiety, despair, hopelessness. We know that optimism is, there's actually pretty big literature on the role of optimism in health through multiple pathways. What does it do to a kid to grow up in a neighborhood where all that they see is despair and failure? But another major way in which neighborhoods can influence health that I think people, especially don't think of, but that may be one of the most major ones, is how the quality of the schools goes along with the neighborhood. And I'll talk in a minute about how the sort of the biologically plausible pathways through which education can influence health. But I do want to point out here that because of racial segregation, Blacks and Latinos are tracked into much less healthy neighborhoods than whites of a similar income. And how often, for those of you who read the medical literature, the scientific literature, how often have you seen an article that says, well, we controlled for income, or we controlled for education, and we still saw racial and ethnic differences, therefore it must be genetic? Don't buy it. There is so much that's unmeasured, even after you've measured income and education. So one of the things that's very different by race is neighborhood conditions. Another thing that's very different by race is wealth. Poor whites have 400 times the wealth of poor Blacks. And you tell me that people are equivalent. Conditions in childhood. A middle class or more affluent Black or Latino person now is more likely than their sort of same income education white counterpart now, much more likely to have not been so advantaged in childhood. And childhood conditions can have very, very powerful effects on health that don't show up until later in adulthood. So there's a whole array of characteristics that differ between by race or ethnic group. And a lot of them, they differ at the same level of income. So it's not enough to have just controlled for education or income. Now I just want to walk you through some ways in which education might affect health. And this is the way that I think, for those of you who are in the health field, this pathway is very familiar. It's the one that goes through how knowledge and coping skills and problem solving lead to better behaviors and better ability to manage one's health or disease. But there is, I think, there is a literature that tells us that there are other very biologically plausible pathways from education to health. And here's another one, and this is a category of pathways that go from education to work, because of course, as I noted a few minutes ago, our education is the prime determinant of the kind of work that we can get. So the work, then the kind of work we can get determines the income, and then I just a couple of minutes ago went through some plausible ways in which income could influence health. But there are other ways in which work could influence health in addition to its influence on income. And one of those is by shaping the working conditions. And there's been some very interesting work that has shown that the extent to which we feel some degree of autonomy at work actually looks like that has very powerful effects on health and may be an important part of explaining socioeconomic differences in health. So what the literature has shown is that it's both the amount of the external demand that's on you, of somebody on top of you telling you what to do, but also your degree of your feeling of some latitude in making decisions about how it is that you meet that demand, and so that a particularly toxic combination is a high demand and low control. And that looks like it has direct physiological effects, and people think probably through the same pathways that are involved in stress. I want to make a comment here, again, for those of you with a scientific background. For each one of the links that I'm making, there's obviously not time to discuss what the literature is to back it up, but for each one of these links, there is a credible literature from credible experts. I'm not saying that there is 100% consensus in the field. I'm not saying that there aren't some experts who might question some of these links, but there is a critical mass of literature in respected journals from respected experts on each one of these links. So here's another category, another way in which education can influence health, and called this the psychosocial pathways. Now, the last pathway that I talked about that went through work, education to work, and then work to working conditions, and the psychosocial conditions at work. So that was psychosocial, but here are other psychosocial conditions that don't necessarily go through work. One is how our educational attainment affects our social standing. So where we see ourselves and where we are seen in a social pecking order. And that social standing can have a lot to do with the kind of resources that we have access to. It also affects our perceived status, how we see ourselves in the world. And there are a number of studies, very intriguing studies, that have shown that no matter how others perceive you, your own view of where you are in a social hierarchy can actually influence your health as well, which I think is very fascinating. And to me, that literature actually sheds some light on explaining how, as part of the explanations for racial and ethnic disparities in health, many of us feel that experiences related to racial discrimination are part of the picture, an important part of the picture, and that could go through some of the same pathways as this perceived social status? Do you perceive that you're a member of the out group? You're not in the in group. Social networks, that's a big source of access to social and economic resources. Does somebody tell you about there's a job over there? You know, I'll put in a good word for you, you know, for that job or to get into that school. The norms in our social networks can have a powerful effect on our own health behaviors and have an effect on health in that way. Social networks can be a source of social support, but they can also be a source of stress. And what am I talking about there? Well, for many people of color who've been upwardly mobile, they have family and they have friends who were not so successful, who are tugging at them. And it can be a constant tug to help them out. And so their social networks actually are more of a stressor than a source of additional resources. And then just educational attainment has, for a long time, we've known that it influences our beliefs, control beliefs, which you could think of just our feelings of powerlessness or mastery, self-efficacy, our ability to change what happens, to influence what happens to us. If you don't believe that anything you do is going to have an effect, then why struggle? Why struggle to have healthier behaviors? So that can be very, very important in shaping how we cope. And control beliefs can be very important in shaping our response to stressors. And then again, all of those things in that third column, there is a literature tying all of those with health through various pathways. I want to make another comment. I've just shown you 3 kind of messy, busy categories of pathways through which education could influence health. Well, I mean, the fact is there's evidence that all of those pathways operate. It's not, the question is not which one is it. There's good evidence that maybe not all of the time for everyone, but that on the whole, all of those pathways are important. And keep that a picture in your mind of this together with the previous slide and the previous slide. And you'll see that there's no way to design a neat little randomized controlled trial of the effect of education on health. And that the kind of evidence that we need on what works and what doesn't work is generally not going to come from randomized trials. And that does not mean that it's not evidence, because there's rigorous, very rigorous science that can be done and that needs to be done that doesn't have to use randomized trials. We have big and many toolkits of techniques to minimize bias and reduce confounding. So I mentioned the link between stress and health, and Dr. Henry Sanchez mentioned that also. And there have just been these stunning advances in neuroscience in the last decade or two that they've enabled us to understand how social factors like income, like education, can get into the body. How do they get under the skin? And there are multiple systems involved. And I think right now there is a consensus among experts that chronic stress is a very likely major contributor to both the socioeconomic gradient in health and to racial or ethnic disparities in health. Acute stress doesn't look like it's as toxic, and Dr. Henry Sanchez used the term toxic stress, that acute stressors, like we're going to take an exam, we're going to give a talk, those, yes, they're stressful, but that's a kind of stress that doesn't dysregulate our physiological systems. It's the exposure over a long period of time to chronic stress, and surprisingly enough, it doesn't have to be very dramatic events that are happening, just stressful everyday living, the kind of stresses that come from coping every day with inadequate economic resources, the kind of stresses that come every day from dealing with the legacy of racial discrimination, even if no one is trying to discriminate. that those ordinary kinds of stressors, if sustained, can have a very toxic effect and cause dysregulation of physiologic systems, both the immune system and the HPA axis. For those of you know, I don't know what percentage of the audience are clinicians. So here I'll just show, I think a lot, when people think about the physiology of stress, the first thing they think of is the hypothalamic pituitary adrenal axis. It is not the only system that's involved in stress responses, but it's been one that's been fairly well described. And the point of this diagram was really just to show how, you know, we experience a stressor, and, you know, that has an effect on one part of the brain, and then that part of the brain signals another part of the brain, and then the other part of the brain signals the adrenals, which then start pumping out cortisol. And it's that chronic exposure to high levels of cortisol that looks like it does the damage, and people believe is a major factor in premature mortality, in chronic disease, heart disease, particularly heart disease and probably diabetes. So who has the most stress? Now, I was brought up to believe that the people who have the most stress are like people like all of us in this room, right? Like active professionals. You know, we have all of these worries, these reports we have to write, and these PowerPoint, you know, demonstrations we have to do, and we're the ones with the stress. And that, I mean, I think the way that belief goes, that the people at the bottom, you know, they don't have to take their work home with them, and so they don't have as much stress at work. And that really has been a very prevalent belief, but it's not evidence-based. And here I'm just showing you some evidence just from research that my colleagues and I have done in California. These are California data, women who have recently given birth, and this shows you the percentage of women who experienced separation or divorce during pregnancy, according to income. And again, here it's the 5 income groups, and you just see this difference. It's the gradient. It's most dramatic, you know, at the extremes, but it's also there for each step. Again, what looks like a dose response relationship. We looked at that. It was basically the same pattern for every one of 11 major stressors that we looked at, and when we looked at the number of stressors, because the number of stressors is thought to be potentially very important in itself, regardless of how dramatic those stressors are. It looks like there's something about the number and how that challenges our ability to cope. It was the same basic pattern that you see here. So who has the most stress? It's not at the top of the pecking order. Another area in which knowledge has just really exploded over the last 15 to 20 years is looking at the role of early childhood experiences. And we now know that the experiences that we have during early childhood are major determinants of the health that's going to show up decades later in the form of cardiovascular disease, diabetes, premature mortality. There is a lot of data showing that there are very lasting effects of early childhood deprivation, and it's in multiple domains, including economic hardship, but also other kinds of family hardship, and as Dr. Henry Sanchez talked about, neglect, or as an aspect of neglect, the kind of stimulation that children get in those first early years. And that what scientists have seen is that that poor children they can actually see differences in their brain architecture compared with the brain architecture of
children from better off families, and in a lot of cases what they've attributed this to is differences in the cognitive stimulation that those kids are getting, so that the kids from the higher income, higher education families, their parents are reading to them, they're getting positive stimulation, and the poorer kids are not, for a variety of reasons, one of which is that their parents are just basically hanging on to the ledge, trying to survive and keeping a roof over everybody's heads. And that it has been shown, so that's the depressing news, but the good news is that a lot of those changes can actually be reversed with well-done early childhood interventions and high-quality early Head Start type programs. I'm not talking about the cheap version of Head Start. I'm talking about the kind that costs a bit, but actually has been shown to be cost-effective in the long run when you look at health later and when you look at rates of incarceration, educational attainment, working in adulthood, a good investment. So early childhood, in understanding the social determinants of health, the conditions in early childhood are probably the most important. So I love this quote from somebody at UC Davis, which is that genetics loads the gun, but the environment pulls the trigger. And it captures it for me. And this whole, and Dr. Henry Sanchez talked about this also, that the whole, is it nature versus nurture debate? That debate has been turned on its head, because we now we know that it's both. And somebody could have a very deleterious genetic endowment, but that deleterious genetic endowment may not be expressed unless they're exposed to unfavorable circumstances in the environment, or correspondingly somebody may have a good gene and the environment, and by which I mean either the physical or the social environment, and there's really good evidence on that it includes the social environment, that the environment, social or physical, can determine whether that good gene gets expressed or not. The term biological embedding is one that's become more widely used, and for how experiences in early childhood, very, very early on, including experiences in utero, may affect physiology in ways that are very lasting. It also applies to epigenetics, in the sense that what has been found is that some of the epigenetic changes that have happened, that have occurred, some of those can be inherited. So talk about turning nature versus nurture completely on its head. And so this is very important in understanding how health risk and social disadvantage get transmitted, not just across somebody's lifetime, but across generations. And our policies can alter the environments, the social and physical environments, the exposures in those environments that can trigger good genes or suppress bad genes. So what about racial or ethnic disparities? For many health indicators, not all of them, but for many health indicators, racial or ethnic disparities disappear entirely, or they're greatly reduced after controlling for socioeconomic differences. Few health studies, medical studies, few of them control adequately for socioeconomic differences. But that is not to say that that's the whole story with racial ethnic differences. There are these, there are other reasons, and I'll get to that in a minute, but I want to say right now that because of what has often been termed structural racism, in other words, the racial discrimination that's just built into structures, even when no one
is intending to discriminate anymore, and it's best embodied in racial segregation. So if you think about it, when you think about how important resources in a neighborhood are and how racial segregation is tracking the kids of African Americans and Latinos into disadvantaged neighborhood circumstances, that's an example of structural racism. So because of that, the legacy of racial discrimination, that was legal not that long ago. I mean, it's only been since the 50s and the 60s that it became illegal to discriminate. Now it's illegal to discriminate, but the structures persist, unfortunately, and this relegates Blacks and Latinos to lower wealth, income, education levels, and unhealthier occupations, unhealthier neighborhoods. So for all of these reasons, race and ethnic group captures unmeasured socioeconomic differences. So we have all these studies that don't do a good job of measuring socioeconomic differences, but they've got race or ethnic group in there. And what they're not seeing is that and they're seeing big differences by race or ethnicity, but they're not understanding that a lot of that, all or part or potentially all of that, may have to do with socioeconomic conditions because of the legacy of racial discrimination. So that's one way in which racial and ethnic disparities in health get created because of structural racism. But we have good evidence to believe that discrimination could affect health in other ways, including direct effects on the HPA axis, on the autonomic nervous system, on immune and inflammatory mechanisms, vascular effects, that this literature on stress and this physiology of stress is informing our understanding of how experiences of racism could affect health. In terms of what could be done about it, well, policies could reduce a lot of the racial disparities in the social determinants of health. By tackling the disparities in the social determinants of health may be the most effective way to do something about racial and ethnic disparities in health. So, do we know enough to act right now? I mean, with that as the background, that sort of social determinants 101 background, there's a huge amount that we don't know. There's great complexity, and we do know that an intervention that may work beautifully in one setting and with one population may not work well in another setting and another population. One of the most frustrating things, I think, is this understanding that the health effects of social determinants may not show up for decades. So the experiences that little kids are having before age 5, that maybe they're not going to show up until they're in their 50s, their 60s, in terms of diabetes, cardiovascular disease, premature mortality. This is very frustrating. It is very hard to design a study to follow people longitudinally over time. And so there's a lot of, because of the complexity and because of the time lag, there is a lack of certainty about many questions that there are in the field. But I think that when we weigh what the risk is of acting on not completely certain knowledge, the risk of that versus the risk of continuing with the status quo, with the morally and economically unacceptable racial and ethnic and socioeconomic disparities in health, I think the imperative is there to act, and not to act mindlessly or without evidence, but to act based on the best available knowledge. Someone has commented that they doubted that anybody had ever run a randomized controlled trial of parachutes before they supplied parachutes to members of the Air Force who had to had to exit planes. So just to wrap up now, I'll give you a minute to look at this. So there are a lot of things that we don't know, but one of the things that we know is that this doesn't work. And part of what I like about this cartoon, it's, of course, it's a caricature, but it caricatures this, this notion that such an important part of what we do is to inform people and inform them that they ought to behave better and exhort them to behave better, leaving it to that individual to behave better. And this is another one that we know doesn't work. So here's health. And, where we've been, I think, has been this awareness, of the importance of medical care. And then in the last 4 or 5 decades, increasing awareness of how important individual behaviors for which people are individually responsible. That's been the way that most of our interventions have been designed. So could it be that the answer to that question of why it is that we spend more than anybody else on medical care and yet we have worse health than virtually all other industrialized countries, could the answer be that our focus has been too narrow? And we haven't been looking at what not only determines who gets medical care and of what quality, but we haven't been looking at what shapes the behaviors, at the living and working conditions in homes and communities. And we haven't been looking at how these living and working conditions actually can directly affect health, deliberately making sure that this arch is touching the health bar there, how they can directly affect health. We haven't been taking that into consideration. And we haven't been taking into consideration at a more fundamental level what it is that sorts people into healthy and unhealthy living conditions, because there really aren't very many people who choose to raise their kids in unhealthy neighborhoods. It's, that our ability to live in healthy conditions, to live and work and send our kids to schools in healthy conditions is determined by the kind of economic and social resources and opportunities that we have. What do I mean by those? I'm talking about income, education, racial inequality as major determinants of living and working conditions in homes and communities. And it would be really foolish to say, oh, it's all societal responsibility and there's no individual responsibility. I mean, we all know, I think many of us in this room are probably pretty advantaged, at least now, at this point in our lives, and how hard it is to eat right and get enough exercise, the struggle that represents, even for somebody who's got everything going for you. Well, you imagine what it's like to try to do that when you are literally hanging on by your fingernails, trying to keep your family from becoming homeless. Well, that of course individual responsibility matters, but what we know now is that there are too many people in the U.S. who face obstacles to health and to making healthy decisions. They face obstacles that only society can do something about. And the last graphic were developed as part of the Robert Wood Johnson Commission to Build a Healthier America, which is essentially a commission on the social determinants of health. And this was developed by the communications people to try to illustrate this concept that the social advantages and the health advantages that you have at one stage of life shape the social advantages and the health advantages you have at the next stage of your life. But then they also shape the advantages of your children. And this is the sort of intergenerational cycle
of social advantage or disadvantage and health advantage or disadvantage. And then just finally, I believe that we do know enough to act now, and that really the biggest challenge to achieving health equity is not the scientific uncertainty, although we have to acknowledge the extent to which there is scientific uncertainty, but that's not the biggest challenge. The biggest obstacles are political. And if you think about it, the pursuing equity inevitably means that you're swimming upstream against the prevailing current. And that because of that, you're going to be challenged. So it's a good idea to be sure that you know which direction you're heading in, and that's why I started with the definitions. But we also, I think,